Hello, everyone, and welcome to another episode of ALS Clinical Trials Unboxed, brought to you by ALS Canada. We have a really special one here today. I am the Chief Scientific Officer, David Taylor, and it's a huge pleasure. I have to say, I'm sitting next to a room in our offices named after someone named Melanie York, and Melanie York was instrumental at ALS Canada. When she said, until we can treat the disease, we need to treat the person. And that really led to actually a change at ALS Canada that we had to start seeing research as not just disease modifying therapies, but also management, clinical management research, how important that was. So it's a huge pleasure to be able to introduce Professor David Berlowitz, who's coming to us all the way from Australia today, very early in the morning. He is a professor at the University of Melbourne. He's a respiratory physiotherapist, an expert in epidemiology, imaging, machine learning, sleep and respiratory physiology, many different things. When you hear him speak, you'll understand that he is a master of many things, and we are so grateful that he is here today to present to us the study that's currently ongoing between Australia and Canada on trying to evolve our practices with non-invasive ventilation. So without further ado, I will pass off to you, Professor Berlowitz. Thank you so much for being here.
Thank you very much, Dave. Thanks for the opportunity to present. And so this is the trial. This is known by us. So the trial is around using a sleep study to help us make non-invasive ventilation the best we can in ALS. So it is three-letter acronyms: PSG for NIV in MND in Australia, or ALS. So yes, hence it's 3TLA. And I'm obviously presenting on behalf of the study group. And before I start, I want to acknowledge the traditional custodians on the land where we developed and run this trial, which for me is the Wurundjeri people of the Kulin Nation in Australia. And I give my respects to their knowledge and their history. So I'm just going to go quickly through a little bit of background here. And the thing that we do know about non-invasive ventilation in ALS is that we have one randomized controlled trial, which was done, quite a few years ago now, that shows that it works. It was in 2010. And this little graph here shows in the blue the people who had NIV had better survival than those who did not have non-invasive ventilation. And you saw a picture of non-invasive ventilation on the previous slide. But the difference was different between people who had trouble with bulbar function at the time of randomization, where the clear benefit was there in those with a well-functioning upper airway at the time versus those who didn't. When those lines cross, the difference is not as large. This is where you dig into that, and you can see here that the bulbar group had a much bigger survival than those without. But I've spoken to the primary author about this. What we can see here is that, in fact, a lot of that difference happened really early. So this trial is probably one of those occasions where we found a positive result, but it was almost by mistake. It was chance. The trial's quite small. It's only got 41 people in it. This does happen in science. We have a 1 in 20 chance that we get it wrong, that we find something that might not be true. So this changed practice, but it also meant we could never do another trial of non-invasive ventilation or not. There was never equipoise. It was never fair to randomize somebody to not have it. So it absolutely was fantastic. It changed quality of life. But it's one of the reasons why it has lagged other treatments coming into practice. When you can't do a randomized controlled trial, you have to think about other ways to skin the cat, other ways to work out whether or not you can get an answer. And so these are data that we assembled with our clinic over almost 20 years, where we looked at everybody who was getting non-invasive ventilation in Melbourne and looked at their survival. And what we found was that the median, the median survival advantage with non-invasive ventilation was 13 months. And so if we think about when this was done, the state of the art, tofersen has obviously changed things for people with SOD1, ALS, but for everybody else, riluzole, the mainstay drug, really only provides sort of 2 to 4 months survival advantage. So here we have a physical therapy that provides a much, much larger advantage in survival. There have been 4 other cohorts who have shown similar things and over the years, and this is from a colleague, Jason Acrivo, at University of Pennsylvania. And what Jason added to this, really importantly, was that it's not just making NIV available to people that matter, it's about ensuring that the NIV is as good as possible so that they can use it. And there does seem to be a cut point, and we know this from sleep study experiments in other people who need non-invasive ventilation for other reasons, that 4 hours is kind of like this magical use point where we get a big difference in the physiology benefit from non-invasive ventilation, as well as symptoms, and in this case, as well as survival. But you'd think, well, everybody should have this. And there's no doubt in the literature and there's no doubt in community practice that everybody should have this. But not everybody gets it. This is what we call an implementation science failure. So this illustrates, say, 100 people across Australia, groups of 10, living with ALS at any one time. From these data are also a bit old, and we think this number is larger now, but from our Australian population registry at the time, less than 20% of Australians ever start non-invasive ventilation. And this is to do with access to clinics, it's to do with provision of care. At the time, it was to do with how the ventilators and other things are funded and supported. And even worse than that, only half of those people who start are ever able to continue using it. So we have this situation where we have arguably the most effective therapy, not arguably, I think truly the most effective therapy for people in terms of improving survival with non-invasive ventilation. And as I said, the last time we have reliable data about this, only 1 in 10 people were actually using it at a level that would confer that benefit. Myself, Mark Howard, who I work with, we had a PhD student called Liam Hannon. He's a respiratory and sleep physiotherapist, physician rather, sorry. He did his PhD, which was a randomized controlled trial of testing whether when we start non-invasive ventilation, if we bring people into the sleep lab, can we make their ventilation better? So just sort of briefly, what we did was bring people in, do a full sleep study, and in half of that group, we optimized their non-invasive ventilation based on what we saw from the squiggly lines on the computer overnight. And in the other half, we didn't alter it. We'd set it up as best we could by the bedside. We had monitoring, telemonitoring in place, although not quite as common then, and we let it run for 10 weeks. And we didn't find what we expected. Science is testing things. We thought we'd find a difference in the number of times people woke up from sleep. And we didn't find anything in lots of other variables as well around sleep. But what we did find is this thing called patient ventilator asynchrony was different between the two groups, and we found usage was different. So patient ventilator asynchrony is when a person's trying to do something and the way the machine's setting, it's trying to do something else, and they get out of sync. And that impairs your breathing, does disrupt your sleep, although it doesn't wake you fully up, as we showed. But what we did find, really importantly, was this is every person in the trial, and the horizontal lines here are the averages. So this is in the sleep study group, and this is in the controls. And you can see they kind of went up and down in a random way. but we did get a difference here overall, and many more people getting improvements in usage in the intervention arm. And not everybody in this study had ALS, so but a large proportion did. And what we found was that what really changed was not just the average usage, which in the people with ALS, the difference was almost an hour and a half. But we also found that the categories that people sat in, that above or below 4 hour way of looking at things, changed in the right direction. People who couldn't use it before the sleep study got more use afterwards, and people who were using it okay beforehand actually fell below. So it did make a difference. It swapped people in categories. So we've gone on to get funding to replicate this in motor neurone disease. And the primary outcome of the trial, exactly the same design, slightly shorter follow-up in the initial period, is to see whether we can move people into this good category. And we've got secondary differences in looking at how they breathe, how strong they are, and how they feel. And then we've got exploratory aims, and we're doing some work around trying to build machine learning algorithms on the back of what we found. And up until about a month ago, we were following people not just for the randomized controlled trial period, but also out for 6 and 12 months to look at outcomes. And in the extension to Canada, which I'll get onto now, we've actually dropped that, and we've dropped it in Australia as well to ensure that we get people into the trial. So we have all of these sites running in Australia, across the country, in Perth, Adelaide, Melbourne, 3 sites in Sydney, and 2 sites in and around Brisbane. However, I started this a while ago. We wrote the grant pre-COVID, and Melbourne was the most locked down place in the world. We had the most number of days where we couldn't go outside, where people didn't feel the same about coming to hospital. And to be fair, it wasn't safe, certainly early on. So everything changed. And in particular, models of care changed. Telehealth didn't used to be as big a thing globally before COVID. Clinical services changed the way they delivered care, and we fundamentally weren't in Kansas anymore. That massively impaired our enrolment rate. This was our planned enrolment, and for us to hit the magic 244 we needed by about now was impossible, despite everything we could do, as you could imagine. And here comes Canada. I'm very fortunate to have been invited by Dr. Reshma Amin there, who is from Sick Kids in Toronto, who led the establishment of the Canadian Home Mechanical Ventilation Research Network. This is a research network that supports ventilation trials across Canada. And there was a call for international trials to come to be brought to Canada. We applied and were successful. Sick Kids is the sponsor. Sunnybrook started enrolling this week, and in Alberta, Calgary and Edmonton are coming on board, as is Manitoba and Winnipeg, probably within the next month, although it's IRB, so it's going to take a little while. And so here we are, and here we're running. The inclusion of Canada gets us much closer. We have funding to get 50. I'm trying to find more money so that we can get all the way through, and we can really answer this question for people living with ALS, and for them to be informed, for them to benefit, and for my clinical colleagues to be armed with the information we need to be able to get this better into care for more people quicker. Thanks very much. Dave, I'll jump back to you.
All right. Thank you very much for that, David. That was fantastic, and really appreciate that Canada could come to the rescue. Um, I'm glad that really works out, and I get to work with some of your colleagues on in the Australian side, and I knew about the trial before I knew it ever was ever coming to Canada, so I think that's exciting. Maybe we could just start with a couple pragmatic questions to start, which is if someone, you mentioned some of the sites that were connected to it, and I think we should be able to support getting that up on our website, even at ALS Canada as well, if that's helpful. But how would people get involved in something like this? And are there specific inclusion, exclusion criteria? I know there's probably a lot, but like a couple key things that people could think
Yep.
about that they might be eligible for such a study.
So this is a study that has a very large implementation science component of it because we want to not only find if it's true, but get a long way down the path of how we make it happen
Yeah.
um, if it's successful. So all of the sites are based in the large ALS clinics in those cities. So if you're going to the primary ALS clinic, you will be exposed to this trial. We have tremendous engagement from the various sites. Um, it's a respiratory trial, but it's embedded in the multidisciplinary clinic at each of those sites, and we seek out kind of people who are interested in the trial and who have those clinics. So presenting it to those clinics is the way to go. The inclusion criteria and exclusion criteria are deliberately very broad because we want to test this in as many people as we can. We don't we don't believe that there's any particular group who are more suited or less suited to this. Anybody who is clinically indicated to start NIV
Okay.
is pretty much eligible to participate in this trial. The challenge in Canada as well as Australia is primarily logistics and distance and the burden of participating, coming back for what is 2 sleep studies
Sure.
over the sort of 11, 12-week period. That's the primary reason why people quite rightly might not be able to incorporate it into their life. But we're trying to, as I say, offer this to as many people as we can.
Okay. Thank you. And so actually on that note, it is, I think you'd mentioned that most of the people or a large proponent or a proportion of them had ALS. There was a question that came in uh, based on the fact that the term MND is often used in Australia. Is this eligible to someone who may have, say, PLS, but is potentially eligible to have NIV?
Yeah, PLS is not excluded from the trial. Kennedy's is not included. And to be fair, so far we're well over 100 now. We actually haven't had anybody with PLS. So that would be a conversation with
Okay.
the site.
Of course.
Um, yep.
Okay. So now I want to dig into a little bit more on, I don't know that everybody gets the perspective that you put at the start that often about NIV comparative to, for example, pharmaceuticals that we put so much emphasis on, so much money behind, right? And it's the allure of the drug that will stop the disease. But at the same time, what you've told us and what, literature tells us and is that there are ways we can manage the disease that are still, after many decades, much better at helping people to survive longer than any of the drugs that we've been able to test and put tons of oomph behind. Why do you think that is? Is it just that piece that I said there, or are there other factors that you think might be why it's hard to get us to rally around this?
Yeah, it's money and time,
Yeah.
to be fair. Um, so you mentioned in your introduction about disease modifying drugs. I mean, NIV is, we don't have brilliant evidence in adults, but certainly there's preclinical evidence that it is a disease modifying therapy that we believe by modifying the experience of having your oxygen drop, but importantly come back up
Yeah.
overnight.
Fair.
Um, we think that's the mechanism by which, certainly in cell culture and in some preclinical animal models, that it does modify survival. So
So,
it is a disease-modifying therapy. However, uh, supplying equipment is not as lucrative as pharma.
fair enough.
Um, the money able to be invested by private industry in particular is orders of magnitude smaller,
Yeah.
but also it's hard work. Um, Taking medications is no fun, but we call them, side effects, and on for most people, most of the time they can be managed. Um, Doing non-invasive ventilation is hard. Physical therapies require somebody to decide every day, or in this case, kind of every night, that this is what I want to do today. Um, and one of the reasons why we're using such complex technology with polysomnography is that that's the only way we can kind of peer under the hood and understand exactly what's happening every breath. Telemonitoring that we have is increasingly useful, but it's not the same. It can tell us about somebody's breathing, but can't often tell us about their sleep, those kind of things. And so the knowing is, and it happens while you're asleep. So being able to make it optimal is really
Hmm.
important. I mean, if this trial succeeds, one of the things we've got running along next to it is a whole bunch of, I work quite closely with engineers at the University of Melbourne, and we've now published a number of papers where we're trying to build algorithms that can detect and classify the patient ventilator asynchrony, the biomarker that I talked about early on. And it's getting pretty darn good, to be honest. Um, and we think with that kind of information, we'll be able to help make the machine smarter. And so we can move further down that translational pathway to what I ultimately want. The vision is to build a ventilator that can detect and respond to
Mm,
people getting weaker and can help them more as they need it. And that's the goal.
yeah.
But
That makes
this,
total
you,
sense. Yeah.
yeah, I mean the uh, as I said, it's complicated. It's a little bit hidden, and the devil's in the detail. So we just need to extract that detail.
Sure. And we need more studies to, we
Yes.
need more oomph and support and funding to go towards this to optimize those things and to get closer to a world where, I mean, that seems like a completely feasible thing in today's world to have a responsive equipment that can ultimately personalize the treatment based on a response. I should add quickly, I know we're only down to a few minutes left, but if someone does have a question, please. Oh, I do see someone in the Q&A. Are there any studies that show that motor neurons respond to alternating O2 levels? Um,
Yeah. So
there you go.
that was what I was
What you were
hinting
saying.
at before. Yeah, there is some cell culture work in particular that does show that survival of cell culture is modified by what we call chronic intermittent hypoxia, which is the model for sleep disordered breathing.
So, I mean, it's interesting to reposition it as a disease modifying therapy. And I wonder actually your thoughts on organizations like ours or MNDA or ALS Association, Fight MND, all of these. We do all kinds of messaging out there to the community about what disease modifying therapies exist, but yet NIV never shows up on there. So I have that question. Do you think we should be repositioning it? And then in that, and this is a loaded question maybe, when we talk about something like clinical trials, where you have some people on NAV and others don't, but we never really balance by that in the statistical outcomes. You've actually got a standard of care disease modifying therapy that could be like changing the results if we don't start to consider it under that sort of paradigm. Does that make sense or?
It makes sense, and I am smiling with joy. So, it particularly for some of the newer agents that are being tested in platform trials, I non-invasive ventilation is understood as a confounder but it's dealt with at randomization.
Mm,
These trials are frequently going now for kind of 16
right.
weeks, and a lot changes in the life of somebody with motor neurone disease over that period,
Yeah.
ALS over that period. And so, yes, an imbalance in exposure, particularly to the delivered dose, so the usage of non-invasive ventilation, I believe is critically important. And we have had meetings with some of the platform trials. We have very good statisticians engaged in our trial who are thinking about how this post-randomization imbalance in exposure might be confounding trials.
Hmm,
And what I'm very concerned about is the risk in the phase 2 trials, in the earlier trials, that we have an agent that may show promise that might
right.
get thrown out.
Right. So
At,
actual false negative or
yes,
yeah.
I yes, I think that's where the rubber will hit the road if it occurs. But moreover, we're possibly missing synergistic synergistic benefits that we might be experiencing depending on the mechanism of action for the drugs that are being tested.
Right.
This is speculation. I don't
Sure.
know for sure, but I'd really hate us to miss something that was sitting in front of us because we didn't look hard enough.
Sure, for a very long time. And
Mm.
I mean, it's interesting to think about something right now where, it could be augmentative to things that we do find that are disease modifying. And if it's got like the complementary aspect to it, which I mean, we're not exactly testing pharmaceuticals that are trying to disease modify in the same way as much. So, I mean, that's really interesting. I think, as we get lower on time, and I have a ton of questions, so we're not going to get to all of them. But I guess I'm just thinking about like what are the next steps in the ecosystem to get us closer to a world where we're using this more optimally. I know that people embrace it. I know it's in guidelines in different places, but maybe it's not in guidelines still to the point of the nuance or detail that you probably would
I,
like.
I think I actually think the guidelines are pretty good.
Oh, good.
What is missing are practice standards that are enforceable.
Okay.
I think it's an implementation science failure around how we operationalize guidelines and how we hold ourselves to account for adherence with the guidelines and the delivery of the care mandated in the well, not mandated, but driven by the guidelines. So I would like to see performance indices,
Okay.
uh, proportions of people. All of the ventilators that we have now are connected via the cloud back to the clinic. There are mechanisms by which we can pool those data, how we can automate reporting, and how we can empower people living with ALS to be advocates for excellent care, um, not just the minimum that the guideline requires, but
Sure.
moving beyond that to ensuring that things that we can quantify, we hold each other to account for delivering them.
Okay. So, in that respect, then, if change were to happen, do you think there's any value in, again, advocacy like organizations that are in specific countries to do more landscape assessments with their local clinical networks and sort of trying to feed those things together? Like, what's something we can do to start? Is it first us understanding where the implementation science is failing and then actually address it head on and say this is where it needs to change as a group? Or
Yeah, look, absolutely. That's the scientific pathway, I think, which is obviously critically important. That's kind of my job. But I do think that agencies such as ALS Canada do have a role for advocacy and for promotion of these physical therapies and others that make living with ALS better. Um, Dave, I just noticed that the question
oh, there is a
from,
question. Sure. If you want to answer that question, then we'll end
yep,
with that. So
yeah,
can
look,
you see it?
yeah, I can. I've pulled
Okay,
it up.
great.
Thanks, Robert. Yes. So you've been using NIV for over 12 months. Congratulations. I think that's great. This is my clinical background. And I think that, excuse me, the mere fact that you've been able to use it for 16 months means that it is almost certainly highly attuned to what you're to tolerate and sleep with. So the optimization is almost certainly occurring in the background through your respiratory care team. But I would strongly encourage you to, to have a conversation with them, maybe to draw them out about how do they know that it's right for you? Because there's a whole bunch of ways. They could look at download traces. They could look at your oxygen overnight. The most important one is they will talk to you and see how you're feeling. So I think that that's the way to know if it's optimized, is to work closely with your respiratory team, because they'll be doing the best they can. And the fact that you're using it means that between the two of you, you're probably doing a pretty good job.
Wonderful. Well, thank you very much, Professor Berlowitz. This has been great. Maybe we can have you back when things are finished and when Canada's helped you get to that lofty goal, and have another conversation. I think there's lots to mine here, and we really appreciate your time today, especially at 5 in the morning in Australia. So thank you everyone for joining another episode of ALS Clinical Trials Unboxed, and we'll see you at the next one. Thanks again. Take care, everyone.
Cheers. Thank you, Dave.